Thank you, Dr. Sir. Kind introduction of me. The number of RFA percutaneous thermal ablation technique in treating GU cancers is increasing nowadays because incidental loma increases.
Laser and next back.
So, RFA, the main role of RFA in cryoablation in treating early GU cancers for cure intent, so accounting for about 80% of my procedure, but the number of percutaneous RFA or cryoablation increasing, but also in treating late GU cancers for palliation. The accounting for 10% of my procedure, percutaneous ablation therapy does not improve long-term outcomes, but better life qualities. This is the RFA or cryoablation rationale for treating GU cancers. EUA and AUA state thermal ablation has been accepted for one of a good alternative treatment options in poor surgical candidate who should run a high risk of postoperative morbidity or mortality because of serious coexisting disease, such as poor cardiopulmonary function, poor control DM, hypertension, any other medical serious disease. So this minimally invasive treatment becomes more and more available in treating early stage GU cancers. But also it is increasing used in treating oligometastatic recurrent GU cancers who are registered to conventional treatments such as surgery, radiation therapy, or chemotherapy. So heat-based thermal ablation modality include radiofrequency ablation, laser, microwave ablation, and focused ultrasound. Among them, RFA and microwave ablation is about popular in treating GU cancers. Treating freezing energy-based thermal ablation technique is so-called cryoablation, which is so-called cryoablation, cryotherapy, or cryosurgery. And reversible electrophoresis does not use heating or freezing energy, but make many folds cellular of tumor cells. From 60 Celsius or more, cell proteins begin to coagulate. The ideal temperature of RFA or microwave keep the tumor tissue temperature ranging 80 to 100 Celsius. In contrast, from minus Celsius or less, cryoablation induces cell death by mechanical damage to tumor cells by iceberg formation or ischemic change due to endocellular damage of vessels. So cryoablation, the optimal device temperature of cryoablation is reached minus 185, but actually practical we can keep tumor temperature ranging from minus 120 to minus 140 Celsius. This table shows long-term outcome of RFA in treating RCC. Many investigators treated many patients. Their mean tumor size is 2 to 3 centimeters. Their mean tumor follow-up period about 60 months, and their 5-year recurrence-free survival rate was only 80%. This table shows the long-term outcome of cryoablation in treating RCC. Many investigators treated many RCCs. Their mean tumor size, 2 to 3 centimeter. Their mean follow-up period was about 16 months. 5-year recurrence-free survival rate is 95% or more. So I think the long-term outcome of cryoablation is slightly better RFA in treating RCC because of less painful during the procedure, a more clear lesion depiction during the procedure, and less harmful to collecting system compared to RFA. This is a recurrent case of renal cell carcinoma in a 55-year-old man. He underwent a partial laparectomy 2 years ago. This CT scan shows exoperic RCC from the right kidney upper prior to partial laparectomy. 1 year later, we can see a focal recurrent cancer at the resection margin. So how do you treat this tumor? I know it is not easy to perform, to repeat partial laparectomy in this case, so I recommend cryoablation. I target this tumor cryoapplicator, and you can see a large ice ball formation to cover RCC and tumor margin. So we can see no residual tumor at the resection margin. And follow-up CT scan. 1 year later, we can see another recurrent small RCC behind the right kidney. How do you treat this tumor? Radiation therapy or chemotherapy? But I recommend additional RFA procedure. So I target this tumor with the RFA electrode. The tumor is completely ablated, still had no recurrent RCC. 3 years passed since RFA's treatment. This is another case of recurrent RCC in a 68-year-old man. He underwent left radical laparectomy 5 years ago. Follow-up CT shows clearly small recurrent RCC in the right psoas muscle. FDG PET shows slight uptake of glucose in the tumor. So how do you treat this tumor? Surgical procedure may increase the probability of mechanical or sensory neurologic deficits. So I recommend percutaneous RFA. I target this tumor, and the tumor is completely ablated. We can see a small mild swelling of psoas muscle, but after RFA, we did not see any neurologic deficit, but just tolerable pain. This is a cystic RCC case in a 60-year-old man. We can see a large, about more than 3 centimeter cystic mass in the left kidney. This tumor shows solid component within the cyst, consistent with Bosniak cyst. So I treated this tumor with RFA. 5 years later, follow-up CT shows no recurrent tumor in the cystic RCC. So I published a paper dealing with a long-term outcome of RFA in treating cystic RCC. The 5-year recurrence-free survival rate as high as 97%. So I think RFA is very useful technique in treating cystic RCC compared to the same size solid tumor. The tumor is more than 3 centimeters. The tumor is a well-controlled RFA. This is another case of large cystic RCC in both kidneys in a 42-year-old female. You can see a large right cystic RCC, about 10 centimeters. You can see another large cystic left RCC is about 6 centimeters. How do you treat this tumor? I think it is not easy to partial nephrectomy in both kidneys, but I recommend RFA. So in case of right cystic RCC, I target this tumor and aspiration, and I perform the RFA, and we can see here hydrodissection to displace around gastrointestinal tract to avoid thermal damage. The tumor is completely ablated RFA. And next, I treated left cystic RCC. I target the solid component of the cystic tumor, but also I performed the aspiration of this tumor, and also hydrodissection was performed to displace gastrointestinal tract. The tumor is well treated with RFA. 2 years later, follow-up CT shows the cystic RCC markedly decreased in size. We cannot see any residual tumor or metastatic disease. So aspiration and percutaneous RFA is also very useful technique to avoid radical nephrectomy in treating large cystic RCC. This table shows RFA outcome of adrenal metastasis. Many investigators treated many metastatic tumors. Their mean tumor size about 3 to 4 centimeters of metastatic tumor, and their mean follow-up period less than 3 years, and their local control rate was only 80%. It is considered stage 4 metastatic adrenal tumors, so it's not easy to control adrenal metastatic tumor, but also even though we treated adrenal metastasis during the follow-up, we can easily see a recurrent tumor in the body part. This is a recurrent pheochromocytoma in a 35-year-old woman with bony Lindau disease. She underwent already total right adrenalectomy and partial left adrenalectomy. So we can see a very small residual left adrenal tissues, but also we can see a small recurrent pheochromocytoma in the medial margin of the residual adrenal tissues. So recently, pheochromocytoma categorized in cancer in WHO classification. So the patient underwent general anesthesia at the eyelid, the patient position prone, and it scan shows left kidney blocking my RFA pathway. So I have to choose transrenal approach, and I touched and penetrating right left pheochromocytoma, but the heart rate or BP was stable. I know when you touch the adrenal pheochromocytoma during the procedure, the BP and heart rate are so fluctuating, but RFA does not influence heart rate or BP when I just touch or penetrating this tumor with the RFA electrode. And I also introduced another 21 gauge needle to perform hydrodissection to displace adjacent organs. And the tumor is well treated with RFA. When I withdraw the RFA needle, I perform the tract ablation to reduce bleeding. You can see no residual tumor in the pheochromocytoma and no significant bleeding from the left kidney. But also she did not have complete adrenal insufficiency after RFA. This is a recurrent pheochromocytoma case in a 55-year-old female. She underwent right adrenalectomy a few years ago. We can see a recurrent pheochromocytoma in the right adrenalectomy site. Iodine SPECT CT shows hard uptake of iodine in the tumor consistent with recurrent pheochromocytoma. So How do you treat this tumor? I know fibrosis and adhesion is make operation so difficult to resect these tumors, but also it's not easy to perform RFA to treat this tumor because of fibrosis and adhesion. But I had a very difficulty in penetrating this tumor with RFA electrode, but I managed to treat this tumor. So follow-up CT shows no residual tumor in the recurrent pheochromocytoma. This is other metastatic cases. In a 56-year-old man, he underwent right radical nephrectomy and adrenalectomy 10 years ago due to RCC. We can see a large metastatic tumor in the left adrenal gland. I target this tumor with RFA electrode. I treated here and there within the tumor. Follow-up CT shows no residual tumor in the left adrenal metastatic lesion. However, 4 years later, we can see a multiple metastatic tumor in the liver, a psoas muscle, lumbar vertebra, left kidney, left renal vein. So 1 month later, he died because of multiple organ failures. So I agree, Percutaneous aberration does not improve long-term outcome, but their life quality kept very good prior to their death. This is a case of prostate cancer patient in a 70-year-old man. He underwent radical nephrectomy due to RCC 2006. Preoperative MRI shows pyroid 4 adenocarcinoma in the left prostate gland. So however, after prostatectomy, we can see a rising PSA. So this patient underwent salvage RT 2017. Follow-up MRI shows focal enhancing nodule in the right vas deferens resection site. This MRI was performed due to increasing PSA. More follow-up CT shows the tumor is increased in size, so we concluded this tumor was recurrent. So I recommend this patient to treat with RFA. And colon PET CT shows hot uptake of this tumor consistent with recurrent prostate cancer. So CT shows blocking my RFA pathway rectum. So I performed the hydrodissection to displace rectum and safely target this tumor and treat it. So after treatment of RFA, the patient PSA returned to normal level, almost 0.01 nanogram per milliliter. This is another painful case of metastatic blood cancer including RFA. So we can see a metastatic tumor in the low abdominal metastatic tumor invading bladder and abdominal wall. I target this tumor RFA needle. The tumor is completely ablated, but we see bladder perforation and the follow-up CT scan. So in conclusion, image-guided RFA or cryoablation is useful for local control of early or recurrent GU cancers in post-surgical candidate. So radiologists and urologists need to frequently communicate each other about patient selection. It is the very key for achieving good outcomes. Thank you for your attention.